Welcome to HIV Update, Adherence Advances with New Art Formulations, presented by the University of South Florida at ID Care Live. Today's first session is titled Patient Adherence, a Critical Component of HIV Suppression. My name is Dr. Paul Sachs, and I am Clinical Director of the Division of Infectious Diseases at Brigham and Women's Hospital and Professor of Medicine at Harvard Medical School. Activities on ID Care Live are interactive, allowing us to take your questions in real time throughout this presentation. We encourage you to enter questions at any time in the box below. I'd now like to introduce my co-presenter, Dr. John Brooks, a medical epidemiologist in the Division of HIV/AIDS Prevention at the Centers for Disease Control and Prevention, and a former colleague of mine here in Boston. John, thank you for joining us today. Let's get started.
Thanks, Paul, and welcome everyone in the audience who's here with us today. So let me move ahead to the first slide. We're going to be talking about patient adherence, a critical component of HIV care. I have nothing to disclose, and Dr. Sachs's disclosures are here. So what's all the fuss about adherence and antiretrovirals? Some of us who work in this area, as well as many people who look at HIV disease, look at this as a life-threatening condition. And you'd imagine that every patient would take their medicine as prescribed. But in fact, there's a surprisingly large fraction of persons who have difficulty taking their medication every day. And that's what we're going to talk about. I'm going to be giving advice not just about what you can do to improve adherence in your patients, but also some background about why we make that recommendation and those pieces of advice for you. C. Everett Koop, the Surgeon General who really brought HIV to Americans insofar as making us aware of the problem and increasing public attention to the disease, said very well, drugs don't work in patients who don't take them. That's true for many conditions, but especially for HIV infection. What is it about HIV that makes us worried about resistance? Well, HIV has a very high mutation rate, which means that it is undergoing frequent mutations that could develop into a genetic change in the virus that could make that virus resistant to the medicines we use to treat it. On this graph here from a 2015 paper, the authors showed the resistance frequency, mutation rate rather, in HIV compared to a variety of other viruses. HIV's mutation rate is shown in the pink circles. And I want you to pay attention first that the lower pink circle, what that says cell cultures or plasma RNA, that was the mutation rate measured in a ex vivo system or in a cell culture system. But when these researchers actually took DNA from white blood cells of patients and looked at the rate of mutation within those white blood cells, it was higher. And that's because in our white blood cells there's some factors that may actually promote a higher rate of HIV mutation. Now, most of these mutations are lethal, but with the higher rate of mutation that's occurring, there's more and more opportunity for resistance mutation to develop. What does that mean? That means that first, the virus can develop resistance to the drugs we use to treat it. High mutation rates also mean the virus can develop an ability to avert the immune system. And finally, it means that the virus may overcome vaccine strategies. Just some background about non-adherence. First of all, it's not easily defined. There isn't a gold standard definition for what defines non-adherence. Generally, it's the fraction of doses taken over some period of time, or the extent to which patients are or are not taking their medications, yes or no sorts of answers. I would posit, though, depending on your circumstances, what might be most useful is to consider when is the adherence not beneficial, when is it even potentially harmful that they're not adhering.
Yeah, I mean, I think that's a very good thought, because we all have patients who periodically say, you know, I ask, how often have you missed your dose in the last month? And they go, you know, maybe once, maybe, you know, twice, and that generally isn't so bad.
That's right, and they can be very, for them, they can be very shameful that you missed a dose.
Exactly.
But then you have the other patients who, oh, I missed 3 or 4 in the last week, and that's a lot more worrisome situation. Yeah. I think you should listen to that as well, and we'll talk about that.
Or the kind of patient who hasn't picked up their refills for the last several months.
That's another situation. Yeah, that's very high non-adherence. That's right. Interestingly, in just talking with our patients, you know, if we don't bring up adherence, clinicians have a very poor ability to recognize it. And even when they probe sometimes, their ability is not so great. And unfortunately, we don't have any tools that you can use in a busy clinical setting to help you quickly identify the kind of person who may be non-adherent when you're starting them on medication, or to identify when they're not being adherent while they're on medication. And I think it's interesting over time that although this has classically been a problem, that is non-adherence has been a problem, in developed countries where we have a lot of choice, It's also becoming a problem in resource-constrained settings as programs like the President's Emergency Plan for AIDS Relief is making medication available to so many people who didn't have it previously. Now we're seeing adherence in these settings as well, rather non-adherence issues in these settings as well. So I want to take a moment here to kind of illustrate sort of how you define adherence will determine sort of what you measure. These are data from a CDC study called the Medical Monitoring Project. This is a survey of patients in care. It's a large representative sample, and these are data from the period 2007 to 2008. Asking about non-adherence 3 ways. We asked the patients in the last 48 hours, tell me if you've ever missed a dose of your pills, spoonful of medicine, injection. Second is a schedule non-adherence. Over the last 48 hours, how often have you not conformed to the schedule that was recommended? You didn't take it twice a day, you took it once a day. Or you didn't take it every 8 hours, you took it once. Or just instruction non-adherence. They're not following the advice of how to take the medicine. If we said to take it with food, they forgot that. Or if you said take it on an empty stomach, they didn't follow that direction. Now you can see that for each of these you get a different percentage. And actually when you ask about all 3 and you get sort of a combined result of yes on any of these 3 measures, the adherence rate, non-adherence rate is as high as 38%. So it really depends on how you ask the question.
And when you think about some of our ART regimens, I'm thinking of rilpivirine-based regimens, which are really very well tolerated in the people who are quite adherent to it. But they could miss a few of these things, like not taking with food, not taking and it might have an impact. So.
Right, and that's a good point, because it means that we have to consider not just the frequency of dosing, but some of the circumstances around the dosing to make sure that patients are getting the benefit of the medication
Maybe
they're taking.
popping a little acid-reducing therapy. It's just the rilpivirine tolerability is counterbalanced by the need absolutely to take it correctly.
Yeah, that's exactly right. Why are the reasons that people miss taking their medicine? Well, as you might, and this is again data from the Medical Monitoring Project, not surprisingly, the leading reason is I forgot. 40% of people, I forgot. We all forget. We're human beings. So it's not surprising. And we'll talk about ways we can help people remember. A disturbance in your daily routine, like you take a trip, and there's a change in what you do every day. That's another reason people forget to take their medicine, and particularly antiretrovirals, and then a problem with prescription or refill. And this is actually an unfortunate one, that patients who are run out of their medicine on a weekend and can't get it refilled, or have some other barrier to getting their medicine refilled on a regular basis. I want folks to pay attention, too, towards the bottom of this list to a couple of things that, although they may not be particularly prevalent, are also very important in risk for non-adherence. Depression or feeling overwhelmed, about 3% of folks. Money or insurance issues. The inability to pay for the medicine we're prescribing can be, for some people, a very, very high barrier. And then look at the very bottom. I like the fact that in this study, being homeless was not a reason why people couldn't take their medicine. And to me, what that's saying is we shouldn't use homelessness, for instance, as a reason not to prescribe. People who are homeless can take their medicine as prescribed, given the right support. So let's go through some of the factors that have been associated with low adherence for the folks here today. First is the category of comorbidity and psychosocial factors. Current substance use, including alcohol, can be is something that can really get in the way of people sticking to a pattern. Mental health and physical health problems, such as depression, anxiety, cognitive impairment, or poor vision. If you forget what the doctor told you, you need to be able to read what's on the bottle, and not everybody is able to do that. Low perceived quality of life or life satisfaction. If I don't think this is going to help me, why bother taking it? And lack of social support can be very helpful to patients if they have social support to remind them to take their medicine. And then I think negative attitudes and beliefs about HIV disease that may be associated with denial, non-disclosure, or stigma.
Yeah, I find that this last one is really very difficult to deal with in practice. When you have someone who feels that taking the medications is a reminder that they have HIV and they feel self-stigma about that, it really creates a bad reinforcing cycle, and they end up often just stopping because they don't like the fact that they're HIV positive.
I know, it's a very difficult problem to deal with. This is a place, I think, where as the clinic, we may be able to be the patient's cheerleader a bit, insofar as when they come in, we can reinforce that, yeah, you've got a bad condition, let's say, but we're going to help you get through it and get around it, and we're going to support you here. I mean, it's hard for us to erase or deal with things that are so far beyond our control as doctors, but we can create an environment that at least is very open and positive towards the patient who's coming in.
Great.
Another whole group of factors that have been associated with low adherence in multiple studies are this area of knowledge and competence regarding adherence. Low literacy, and especially with regarding health information and regimen-related instructions, is a big area. Some people, we're giving them a lot of information. You got to take this twice a day. You got to take it with food. If you miss a dose, it's okay to catch up 8 hours later. That's a lot of information for some people. So working with them to get through that can be a challenge. And then lack of knowledge and understanding about treatment's benefits or the importance of high adherence for health and to suppress the virus, and clear regimen instructions. Sometimes we forget to remind people, oh yeah, you're taking this medicine because it's going to help you. We just assume everybody knows that. And
yeah.
I've been amazed at, oh, this is going to suppress my virus. Especially people who have multiple medical problems going on. Being very clear about what this is doing is important.
I like to use the explicit phrase, if you take these medications as directed, you will not die of AIDS.
Yeah.
I mean, sometimes something that's so obvious to us needs to be stated explicitly and be a real motivator to patients.
Right, I totally agree with you. And I also think adding in that if you take these medicines as prescribed, you are going to reduce your risk of giving this infection to anybody else. For some people, this is an unspoken burden they're carrying around.
Right.
And when you can relieve them of that burden, I've had patients get huge
motivation. Definitely.
Yeah. Negative attitudes or beliefs about treatment. Unfortunately, some people in our country don't trust the government, don't trust the medical system. It's going to be hard to trust their provider. I'm coming from both, I guess, the government and the medical system. But, addressing head-on mistrust or misconceptions or doubts about treatment effectiveness. And it may not be that patients provide this spontaneously, but if you get a hint about that, my friend started these medicines and he died anyway. Mm-hmm. That can be an entree to kind of explore what may be going on. And then low confidence in the ability to follow regimens or limited self-management skills. That's especially a problem, I think, with folks who have thought disorder, who are being treated for their problem. But that can be true of other people who think that this is going to be a very complex undertaking. They may remember the old days. Lots of pills, lots of dosing. I can't manage this. And the best news you can give them is, well, guess what? There's a good chance you're going to be able to get on a regimen that's one pill once a day. And really, that usually can boost their confidence substantially. And then I just want to talk about some other factors that have been associated with low adherence. And not surprisingly, multiple or complex regimens make it difficult to adhere. Shown here is a figure from a New England Journal paper where they cited some research by Claxton et al. In 2001, showing very elegantly, not necessarily with HIV disease, but in a different context, that the more doses you got to take a day, the less likely people are to be successful at doing that. Side effects can be an enormous barrier. Now, we're lucky nowadays that many of the regimens we are able to offer people have fewer and fewer side effects.
Yes, when you were an ID fellow.
It was horrible!
Right, it was every 8-hour indinavir.
Oh my, and alfinavir is another one. Right. Well, we were managing
the diarrhea.
We were managing side effects all the time.
Exactly.
And we absolutely have side effects still.
Yeah.
But they're not as treatment limiting as they have been before. Now, there will be patients who, no matter what, the pill's too big to swallow, I feel nauseated, I feel tired. Got to work with those folks hard to get them through that. But it's not like the old days. No. And people still do, even some regimens. There are some substantial side effects you need to be aware of. Yeah. A chaotic lifestyle or lack of a daily routine, that can really make it difficult to do anything on a regular basis if you don't have your life together. And this one is important, I think. Lack of attendance at HIV care visits. If your patient misses a visit, that is a clear signal that something's going on and they are very likely to be not adherent. I mean, if they're not being adherent to care, how adherent are they to actually taking the pills you prescribe?
Right. I've always, I always say to our group, it's not the people who show up that we're worried about adherence so much. It's the people who don't show up. Right. They're the ones who really need to chase down.
That's right. And if you have a clinic manager or a social worker or someone in your clinic who can routinely go through the roles of your patients and note who's not shown up recently, you might be able to reach out to that person.
Absolutely.
We don't see what doesn't come in sometimes. Yeah. And finding a way to keep refreshing your memory about who haven't I seen in a while, you might pick somebody up and help them. Some demographic factors have been associated with low adherence: younger age, male gender, racial ethnic minority. And then these I really think are important: poor patient-doctor relationship. Cultural competence is critical. You need to understand where people are coming from and give your patients a choice. We know there are good data that show that patients often do better with physicians who are of their same racial ethnic group or of their same gender or age group. That's not universal, but just be aware that that may be a factor and offer people choice. If I'm not the right doctor for you, that's okay. We have other people you can see. I'd rather you get treated than you not come back. And then lastly, language barrier, and that's particularly important in some parts of this country with Spanish. We have a lot of people who are good Spanish speakers, but often we found that Hispanic Latino patients with HIV can face difficulty with language barrier. That's true for any foreign language, but that's the one that's probably most widely spoken in the U.S. today. So I wanted to show you here now a study we did in that MMP study I mentioned before, again asking adherence by a variety of different methods over the last 48 hours. How were you doing according to the dose definition, the schedule definition, and the instruction definition? And then what were the factors associated with non-adherence according to each of those definitions? And what I'll highlight first is that there were only 2 factors that were associated with non-adherence by all 3 definitions. Younger age, not a surprise to anyone who's taken care of teenagers, and binge drinking in the last 30 days. The others in here, which are important, were not uniformly associated with non-adherence. That's not to say that they're not associated with non-adherence. It's just that these were particularly highly associated. What I'd also like to point out, which may be disappointing to some of us who like to talk to patients about the reasons they need to be adherents, informing a patient about the risk for resistance related to non-adherence doesn't seem to really be associated with an improvement or a detriment in their ability to adhere to medication. So although you may feel compelled to talk with patients about it, I think we might be able to give ourselves a little bit of forgiveness that if you miss that in your discussion, it's probably doing no harm. There's some patients that will definitely resonate with, but clearly not all. So what are our recommendations to improve adherence? And let me just say now that the CDC has published guidelines that we generally refer to briefly as prevention for positives, but the formal name is recommendations for HIV providers with adults and adolescents who have HIV in the United States. This is a document that will be available today from the website. You can download the PDF. It's also available on our CDC website. And it contains a lot more detail about what I'm going to go through right now, as well as some of the background.
And it's our taxpayer dollars
paying
for it.
It is your taxpayer dollars. Please download it. You've got to print it at your own cost. But save a tree. Keep the e-copy. But yeah, use your tax dollars to download this and share it with your patients. So before prescribing, you need to assess for and address a couple of things. Make sure your patient's ready to start antiretroviral therapy. We now recommend that everybody start ART as soon as possible after diagnosis. Not everybody's ready, but you can help make them ready by addressing misinformation, misconceptions, negative beliefs. Yeah,
and the timing depends a lot on their CD4 cell count. I mean, someone with a CD4 cell count of 50, even if they're not ready, we're going to tell them to start. But someone with a CD4 cell count that's normal, you can wait a couple, couple of sessions.
That's right. If someone's over 500, I might be a little more forgiving, although I will say, if they're sexually active with multiple partners and they're engaging in risk behavior, I might be a little more compelled to suggest, you might want to start treatment now to at least reduce your risk of transmitting the infection to others. Assess their coverage for medication costs. Unfortunately, not everybody in America has access to these medications. I think our government and the industry has done a fantastic job at trying to help make medication available to people who need it.
Yeah, I mean, I think some other specialists are envious of the programs that we have for HIV care. It's really remarkable, and when you think about it, especially when you realize that a lot of the people with HIV are indigent or otherwise really get very little in the way of resources. So we're lucky in that way. Yeah, we are.
Usually the step that's necessary is to help them find out how they can get their medication paid for. Because there are ways that I can't think of a single patient in the United States today who we couldn't find a way to help them get the cost paid for. But they may raise this as an issue. And you need to reassure them it's not going to be as expensive as you think. We can help people afford their medicine. Mental illness and harmful substance abuse like binge drinking, clearly associated with non-adherence, addressing these is critical. I wouldn't say I wouldn't start someone who's got some of these issues if I felt that it was going to be addressed properly. But there are other patients in who you may want to take a step back and say, you know what, let's take care of this issue first because there's going to be such a problem with you being able to adhere that we want to cover this and then we can move on maybe to getting you on the medication. And social support's really important. You know, people who live in a vacuum without social support don't do well in general in a lot of health measures. But particularly with adherence, having a buddy or someone who cares about you that you can share with and bring up problems with, it turns out, can be very helpful. When you're prescribing, obviously you want to offer highly effective ART regimens. You want to reassure the patient, I'm giving you the best thing for you and it's going to work. Minimize the pill dosing, the pill burden rather, dosing frequency, and any dietary restrictions. Sometimes our hands are tied with what we can prescribe people, but generally we have a lot of choice. And there's been no time in the history of HIV that we've had such broad choice that we can offer people.
You know, one of the audience members has submitted a question asking about the use of tools such as smartphone apps to remind people to take ART. What do you think about things like that?
Well, there are a lot of them out there. CDC has one, actually, that you can go to our website and download. And I think for some patients, they're very useful. There are people who respond well to that. And I would use everything in my armamentarium that I can get a hold of to help someone who's really failing treatment. And if someone is starting treatment and they're not sure they're going to be able to do it, these apps can be very helpful at giving them a reminder until they can get into the swing of things. And then lastly, it's important to involve the patient in decisions about treatment regimens. Ultimately, the choice to start taking any medication is the patient's decision, and our job is to guide them in making the best decision for themselves. But you've got to remember that and make sure that the patient is vested in what's going on and you're listening to what they're saying. Perhaps most importantly, after you're getting ready to prescribe, is confirm they understand following information. Dosing. Don't just ask, you're going to take this twice a day, right? Better is to ask, how often are you going to take this again? And confirm that they've absorbed the information. If they don't have it, many clinics have access to a pharmacist who can assist with some counseling and teaching. If they don't, you can write down the instructions very clearly. You can find ways to help. You need to go over dietary restrictions if they exist, to be very explicit about what they can and can't do. What to do if you miss a dose. Sometimes we forget to mention this, and the patient comes back and says, oh, I've not missed many doses, but I missed a couple, and I didn't know what to do. And in your mind, you could have just taken it late. It wouldn't have been a problem. Right. But we forget to tell people that sometimes, and I think that's important to remind. Of course, the negative frame message, reminding them of the consequences of missing a dose, that you could increase your risk of progressing with your HIV disease and get an illness associated with advanced disease, developing drug resistance and transmitting to others. You can always spin that in the positive frame as well, but we find that sometimes that negative frame can be a little bit more motivational. Be sure to review any potential side effects and what to do if they occur. I think it's important here to also note to patients that most side effects can be managed, so please bring them to my attention. Because everybody has side effects. Some people don't, but everybody has something. Right. And if there's anything bothering you, we can handle it. And then, of course, this is an important issue. If they're taking other medications, you need to review the interactions with other prescription and non-prescription medications, particularly over-the-counter drugs and recreational drugs and supplements. I mean,
I just to talk about over-the-counter drugs, it's a little bit of a pet peeve of mine, is the approval now of all of these intranasal steroid preparations. So now anyone can go buy fluticasone and other drugs like it, and these, of course, do significantly interact with those HIV regimens that have ritonavir or cobicistat in them. So you have to be very careful to educate people about that, because that can be a very serious interaction.
That's right. Yeah. So. After prescribing, as they're coming in for follow-up appointments, make sure you routinely assess their adherence in a non-judgmental manner. I mean, I don't know what you do, Paul, but I'm often, I don't know, are you like me? Did you miss some of your doses of medicine in the last 3 months?
That's a good one. I'm going to steal that one.
Because, I mean, as we get older, some of us end up taking some medicine. And I'm certainly no saint at being perfectly adherent, and I think that can put you on a level playing field. You don't have to always be the expert in the room, but you need to have the expertise to respond to their questions. Exactly. Make sure they're not having any side effects. And just for the regimen you're giving them, go through them. And be ready for the fact that they may raise some side effects which have nothing to do with antiretroviral therapy. And you can be very reassuring that, well, I don't know why you're having back pain, but I don't think it's the tenofovir.
Right.
Address patients' questions and concerns or challenges, and use these to identify potential problems. And this should be before virologic failure occurs. I mean, that's really the tragic part of non-adherence, is that a person loses ground in preventing progression of disease because they've not been able to adhere. We might have been able to help them before they got to the point that they were experiencing virologic failure. And then, of course, you need to ask every time the patient comes in, has there been a change in their other prescriptions, their over-the-counter drugs, recreational drugs, or supplements, to make sure that there's not some new interaction you need to worry about. Or that they stopped using something that you had previously dosed your antiretrovirals according to, and now they're not taking it. You need to go back to the standard dosing. So some specific advice that we can share to help people improve their adherence. Linking dosing to daily events is really helpful, especially now that we have once-a-day regimens for the people who are able to use those and can get those. It's great. You know, take it with your meal, brushing your teeth, when you go to bed. Millions of women in America have managed to take birth control pills every day, and there's no reason why we can't get people with HIV to kind of integrate some of the methods we've learned in that realm of medicine in this realm as well. Pill boxes, dose reminder alarms, like that app that the listener asked about, can be very helpful, as well as diaries as a reminder so that you check off when you've taken the medicine. And what I'm getting at here is sometimes people will set up a pill box and they can't remember, now this one's open. Did I take that one today or not? And there are some people who it might help for them to actually have a calendar where they're checking off that they took it until they're confident that when they look at their box, they could definitely remember, yeah, I took that one.
One of my patients, when he says when he can't remember whether he takes his medications or not, he just says, I just take them again. And as a result, you know, periodically he runs out of his medicines a little bit early. What he's found, though, is that he can get his refills a week ahead of time, and so he's now got a little buffer. Yeah,
so. I mean, many plans, you know, will begin to offer refill 7 days or 5 days before expiration. Yeah, and for most regimens, I think that's probably a harmless or low risk.
That's what I told him, as long as he's not doing it frequently.
As long as you're not double dosing every day. Devise a plan for what are you going to do if you run out of medicine and you haven't got a place to go. And where I've seen this happen is when people travel. You know, they'll leave their home, they'll go somewhere else, and all of a sudden, oh my gosh, I left my medicine at home. What can I do? Well, the place that I practice, we have a pharmacist who they can call, or a number you can call 24/7, and they can get their refill done. Large pharmaceutical chains, Walgreens, CVS, I imagine Costco and Walmart, all of these, and I'm not promoting one over the other, but you know, many of these companies that are in multiple states share the prescription plan, and you could walk into the pharmacy you're using there and maybe get a refill. And many places will give you a short supply of medicine for all kinds of medical conditions to get you through a period where you've run out. So that you shouldn't be defeated. You want to empower people.
One thing I tell people, though, about the travel is when they cross time zones, if they're obsessive about taking it at a certain time, they don't need to adjust that for the time zone. They don't have to wake up in the middle of the night to keep on that same time. These regimens are forgiving enough that they can just take it at 9 a.m. in the new time zone.
Even when it's a 12-hour difference,
Exactly.
It's okay. You know, it's better that they stick with their daily routine, I think, than it is that they get into having to do a lot of manipulation to get around it. And then avoid treatment interruptions when you're changing routines. Try to make sure that people can take their medicine when they're traveling. We talked about also, we don't have time to talk about it today, but if a person is incarcerated, that can be a very difficult situation maintaining that care. So that's all I had to say, Paul. And I just want to remind people again that the information I've presented a lot of it's available in this CDC document. Encourage folks to go there if they'd like to take that home with them.
So what I'd like to do now is actually present a case, that's adapted from a real case that I saw that presented some very challenging aspects to medication adherence. So Jared is a 23-year-old man, and he was referred for evaluation of his new HIV diagnosis. And he reported that he tested negative 2 years before when he was in college. And then when he graduated from college, he traveled around the country with his boyfriend for several months. And it was kind of a wild trip. He says that he had a lot of unprotected sex, and that also there was a lot of heavy alcohol and cocaine use. So during that trip, he had a prolonged flu, and of course patients use that term flu to describe any illness that involves a fever.
Exactly.
And this particular flu was probably not influenza, as you know.
I have a feeling it will not turn out to be influenza.
Yeah, and he had fever and diarrhea and fatigue, and eventually he got better after feeling lousy for about a week.
Okay.
When he got back here to Boston, he decided that he would break up with his boyfriend. It was a very unhealthy relationship. And he also had heard about PrEP, or pre-exposure prophylaxis.
Good.
So he went to his primary care provider, and he asked about PrEP, and he had no symptoms, and he had normal physical exam. And the primary care provider, who I have to give her credit, she was very attuned to his high-risk sexual activities and the fact that he really needed a thorough baseline evaluation.
Yeah.
And that included, of course, an HIV test, and he was already found to be HIV infected. So unfortunately, he was a little late to getting PrEP. In addition, she screened him for STIs, sexually transmitted infections, and he also had chlamydia. He was treated right then with azithromycin and then referred for further evaluation. And by the way, I should tell you, if you have any questions
I did
about the case.
want to ask a question
Sure.
here. Yeah, I mean, I really applaud that this provider thought about screening for sexually transmitted infection. That's critical. I'm surprised. Tell me, did she consider the orifices where we know that most STIs and MSM occurred, the anal rectum or the oropharynx?
No, she didn't do the comprehensive triple dip, but she did do, she did a urine.
I mean,
chlamydia,
I'm pleased. Yeah, that's great. I just want to remind folks that although some people think that getting a rectal swab and an oropharyngeal swab to check for gonorrhea and chlamydia is not necessarily FDA approved, actually many labs have gotten basically a permission.
A validation.
To do testing, and it's available in most major laboratories now.
Anyway, when we saw Jared, it turns out he had had 2 prior episodes of rectal gonorrhea. He wasn't taking any medications. He's living with 2 roommates and works part-time at a local restaurant. He does acknowledge that he can drink heavily on his days off, and also says that he's not currently using cocaine or other illicit drugs. And he uses a very popular app for periodic sexual encounters with individuals that he often doesn't see again. So in this case, this is a question for the audience, and then you and I can discuss it once they answer. What aspects of the case presentation would make you most worried about medication adherence? And our options are A, the patient's young age, B, the fact that he takes no medications currently and so is not practiced at it, C, has no symptoms, D, the fact that he has heavy alcohol use at times and has used illicit drugs, E, the fact that he's sexually active with multiple partners. And while they're answering this question, John, I thought maybe I would ask you whether this case rings any bells for you, whether this has any resonance for you down in Atlanta.
Yeah, I mean, this is not an unusual situation at all, that we have unfortunately, increasingly, new diagnoses are being made in young MSM. That's a population in which the rate of new HIV diagnoses is going up very steadily and alarmingly. And so, a young man with this presentation is not a new thing. It's, we're seeing too much of it. Well, and also with these sort of comorbidities, right? I'm having multiple partners, I'm drinking or using drugs. The absence of symptoms, sometimes we worry that you need symptoms to motivate you to be adherent. But I would disagree. We want to encourage people to take the medicine so you never develop symptoms.
Interesting. So one of the fascinating things, the audience has responded, the most popular response was A, the patient's young age. But then, a smattering chose all the other choices too, because I guess they all are plausible.
That's right. I think all of these are plausible. That's right. And it would be, young age is a factor I can't alter, so you want to pay attention to that. And there's ample evidence that for many medical conditions, youth makes it difficult to adhere. But you might want to make sure that none of these others are in play and address them in case they are.
What's your opinion about the other choices? Do you have any that stand out for you?
Yeah, I mean, alcohol and drug use is a big one. I think that's very clearly can get in the way of people adhering. I will say that having never taken medication before has never been shown, to the best of my knowledge, to be a predictor of the inability to adhere. You have to give people the chance.
The other one that has come up periodically in the HIV/AIDS world is people aren't really motivated to take medicines if they're asymptomatic.
Right.
But as you noted before, the fact that we can tell them that they won't transmit the virus to others,
Right.
and the fact that we can tell them they won't get AIDS if they take these medicines has been enormously motivating, and I don't think that that is necessarily a predictor either.
I can't say I've ever encountered a patient who, when you've had this discussion, said, oh, you know, I really am feeling perfectly fine.
Right.
And I just, they may posit that as a reason. But.
So moving on,
very good.
his physical exam, entirely normal.
Okay.
And so a whole set of labs are done.
Of course.
You know, we are both trained as infectious disease specialists.
We make them anemic.
The vampires have been to see the patient, and lots of tubes of blood are drawn. And because the tests take a while to come back, he's asked to return in a week to go over the results.
Yep.
And here are his results. His CBC and general chemistries are normal.
Okay.
His CD4 cell count is 1,100, so normal.
Good.
His HV RNA is low at 2,200. He's HLA-B5701 negative. His genotype shows no resistance mutations. He's immune to hepatitis B from immunization, presumably, because he's young enough, and he's hepatitis A and C negative. And interestingly, you mentioned this before, his throat swab for gonorrhea was positive. Unfortunately, we have all those results, but we couldn't go over them with him because he didn't show up for his follow-up appointment, and when we called him, the voicemail was full.
Oh, he's a popular guy. A lot of people calling him.
So we're going to face a quandary now in how to manage this case, and I've given some options for management, and several here. And so the question is, what would you do next? And A, keep trying to call him. B, text him using your personal phone. C, send a letter to his home address. D, contact the Department of Public Health. E, show up at his workplace and tell him how important it is to come in for evaluation and get treatment. Or F, nothing, because follow-up is his responsibility.
All right. Well,
So, you know, I don't want you to answer yet because I want to give our audience a chance to answer, but I have to say, you know, how do you reach out to people who aren't showing up? Or is it the people who aren't showing up that are the problem?
No. I mean, it can be. It certainly can be that people have barriers why they can't show up. But I think it's also incumbent upon us to make sure we're not the barrier, that we're not doing something that we're not somehow getting in the way of them showing up. You know, that we want to make sure we can meet people where they are. This is where cultural competence can be very helpful, although it's not the panacea, but it's an important component to consider. I think, though, you know, we have a tendency to blame the failure on someone else. It's very easy, you know, and it's like, oh, they're a problem patient. How often have you had that? But sometimes it's a problem doctor, and we just didn't hit it off. Maybe they need to see somebody else. Maybe they don't understand what we have to offer. And I think I've also seen patients who are concerned that you've been diagnosed with HIV, and now my doctor is going to turn me in to the health department.
True. In fact, just as we're talking about the health department, the most popular answer was D, contact the Department of Health, which is really actually required by law, isn't it?
It's required by law both because of his HIV, but also because of his gonorrhea diagnosis. And I just want to say that it's not a one-way relationship between clinicians and the Department of Health. The Department of Health, the clinician contacts the Department of Health, who then can manage contact tracing if you're unable to do it yourself. Many jurisdictions, we encourage, actually, the clinicians to do the contact tracing if it's permissible under law. Also, though, the Department of Health can help bring that patient back into care, and we're doing a lot.
They have resources that we don't have in our clinic.
I wouldn't say they're bottomless, but there are resources that we are making resources available through our funding grants to states to help empower health departments to be a colleague and a partner with clinicians to keep patients in care. I just want a couple of the other ones here I wanted to know. What was the second most popular?
Second most popular was send a letter to his house.
Right, and I think that's probably the most sensible thing to do. The fact that he hasn't answered his cell phone messages, maybe he never put in the code. So
below a certain age, voicemail does not exist.
I know. I guess I'm
They're
getting too
never
old.
going to check their voicemail.
Yeah, so. But a letter is what you have to do, first of all, by law in many places, and that's a logical thing to do. I've certainly been tempted with patients who I feel particularly impassioned about to show up at the workplace. But you got to resist that urge.
Got to resist that urge.
Definitely could be a little in their face. And I also wouldn't use your personal phone to call them. I think it's fine to call them with a generic clinic phone or some other, professional number. But I'd just be careful getting too personal.
I think that's good advice. So the DPH, of course, was contacted by law, and also a letter was sent to his house. Ultimately, he just came back a month later. He got his treatment for gonorrhea, and he got treated empirically for chlamydia.
Good.
He did at that visit meet with our social worker and tell her that he had been using cocaine and crystal meth and was very, very worried about that.
Yeah.
Now we've got him here, and he's got a question about whether you'd start him on antiretroviral therapy. And your options are pretty stark here. Yes, it's important both for his health and for public health reasons, or no, the psychosocial situation is too unstable, would focus on trying to get him engaged in substance use treatment. What's the, I don't want you to tell me what you would answer.
Oh, I'm not going to tell you what I'm going to answer until I hear what our friends have to say.
Exactly. But this is, I just want to mention that there's, increasing interest in starting people at their first visit. So obviously the pressure to start people these days is very high. On the other hand, he's got normal T cells.
Right.
His life is chaotic. He's already missed follow-up appointments that are pretty important to him.
Yeah.
So it's a tough
I will
one.
say I was kind of surprised in your example that he didn't start treatment the first visit. Maybe that's Boston. I don't know.
No.
But it's Atlanta too. It's pretty much a national. It's what we recommend.
First visit.
We're moving towards first visit, although there are now programs examining this literal test and treat at that moment. It'll be very interesting to see how those evolve.
Okay.
But it's complex.
Yeah. So what would you answer?
I personally would start him on therapy.
You would?
I'd offer him the opportunity to fail. And the reason I would do that, one, you mentioned he's very concerned about his substance abuse issue. So I think we might be able to manage that in tandem. I feel more confident starting somebody when I know that they're willing to consider managing that problem versus they come in and it's off the table that we're even going to touch that.
Yeah.
Also, he is sexually active with other persons. He's demonstrated that by having an STD. Although we didn't learn exactly what the details are I for that reason want to also consider starting therapy.
So that's what our audience chose mostly too.
Okay.
Yeah,
Wow.
the majority chose yes, they'd start him. So anyway, despite concerns about follow-up, he was started on antiviral therapy. We chose, I should just mention, the single pill, abacavir, lamivudine, dolutegravir, both because it's one pill and also because of this, maybe less likely to get resistance with dolutegravir than with some of the other integrase options.
That barrier is very attractive.
Exactly. Scheduled for follow-up in 2 weeks. Didn't come to that appointment. Then 2 months later he came and says he's feeling fine. He's taken his therapy as directed. His HIV RNA was 3,100. So now we have to figure out what this means. Clearly he's not virologically suppressed.
Right.
He's supposed to be on treatment now for a while. Why did he fail? And your options are A, treatment wasn't potent enough, B, the patient started therapy and adherence became poor, or C, the patient never filled his prescriptions at all. So it's a kind of the viral load as an adherence monitor is coming into play here, or maybe it's just not strong enough.
Well, it's funny. I'm glad you brought that up. First of all, in most patients I'd be, wow, 3,100, not so bad. What was this guy's baseline? Was it 2,500?
Yeah, exactly.
So we haven't really pushed the needle on his viral load as far as I can tell. However, regularly checking viral load is a tried and true way of looking for non-adherence. Exactly.
And in fact, one of our questions here asks, how soon after you start therapy should you check the viral load? And the guidelines say very soon after, a couple of weeks later, just as he was scheduled for his follow-up, but he didn't show up. Anyway, the majority of people chose B, that he started and then his adherence became poor. So he actually never filled the prescription. That was pretty easy to tell. Once he was asked about it, he said, no, I never did. He met with an addictions counselor. He underwent treatment, depression, which seemed to play a role as well. Then he got much more engaged in care, thanks predominantly to the psychiatrist who was seeing him and the social worker who was seeing him. And then now he's taking therapy and doing much better. So that brings me to the end of the case. I do have some questions from our group as well. Do you have any comments about the case?
No, I just want to. This is a very typical case, and really brings up a lot of nice things. I did want to say at the end there, the co-location of addiction therapy or psychological or psychiatric assistance can be very, very helpful. Not necessarily co-located physically in the clinic, but so many of our patients are challenged by these issues that having someone you can good relationship with, you can refer people to in close to real time, so they can really move into that system is going to be very helpful.
Yeah, absolutely. One of the great gifts to our clinical practice was about 4 or 5 years ago. A psychiatrist joined our hospital who was interested in HIV and comes to our clinic and is there. It's actually there. People don't have to go see him.
That's right.
And boy, has that made a difference.
Well, that's a good general principle. Anything you can do to meet people where they are, that's fantastic.
Yeah.
That's fantastic. Good for you.
So a couple of the questions here. There was someone who had interest in hearing more about use of these tests for gonorrhea and chlamydia in, quote, non-approved locations. These are the standard NAT tests, or nucleic acid amplification tests.
NAAT, yeah. So in full disclosure, what I was getting at is they're not FDA approved yet for testing for gonorrhea and chlamydia at the anatomic location of the rectum and the oropharynx. However, there's a way that laboratories can still be permitted and given away to basically approved to do that testing. They have to be given a random sample. I think it's 50 or 100 specimens, and they run them. And if they get them all right, they can get a waiver to be able to do this testing. And the large companies, LabCorp, Quest, and many state and public health laboratories
and hospitals
also are doing this testing. I mean, it's a really important test to do. We know that the majority of STDs, particularly in MSM, are in the mouth and in the butt, essentially. And it's great to screen urine every time, but there have been some elegant studies that demonstrate that you're going to miss a certain fraction of infections.
I've found that some of our patients prefer to get the specimens on their own.
You know what? There's good data that self-collection is perfectly fine.
So, we give them a couple of swabs, they go into the men's room, and they come out, and, the specimens are in a bag, and, for whatever reason, they prefer that, and that actually turns out to be a barrier for some.
It can be a barrier for some. Also, by the way, some people perceive collecting the specimens as a barrier because it's a time commitment. You have to get the patient to undress, collect the specimen, and letting them self-collect it can be something you might be able to integrate into the general practice. Patients, when they're given clear instructions, can do it very, very well.
Someone has asked, at what point do your providers engage medical case managers to assist patients struggling with adherence? I
don't know what your practice is. Everybody in our clinic who's a new patient meets the medical case manager. And they make we try to make friends, and this is going to be your advocate, a friend for you. And our case manager actually likes to touch base. That woman's at every one of our clinic sessions, and she loves to touch base with patients and see how they're doing.
Yeah, we have the rule that they must meet with the social worker before the end of their first visit. Now, of course, if they refuse, then they refuse. But most of the time we'll say, look, you might not be aware of benefits that accrue to you with this diagnosis, insurance benefits, community benefits, et cetera. And then I said, talking to them, it will take you 5 minutes. Of course, it usually takes much longer because they realize what nice people they are. And then,
But the one we use a lot, too, is, the benefit I promote the most is dental care. I mean, America, it's just horrible for our patients how difficult it is for some of them to get good dental care. And our case managers know how to hook people up with services in the community where they may be offered at low or no cost.
Here's another question. What about tablet size? Now, some of these co-formulations are humongous, to use a word that's probably not yet in the dictionary.
Well, I mean, I don't know. They're not as big as some of the versions of trimethoprim sulfamethoxazole I've seen. But they can be pretty big.
So in fact, the one that this patient was prescribed and ultimately went on is very big.
It's a horse pill.
It's one of the downsides of abacavir, lamivudine, dolutegravir. It's very big. I have to say, one of the benefits of the newest single tablet regimen, which is tenofovir, alafenamide, emtricitabine, rilpivirine, is that it is really quite small. I have to say, and for a fraction of patients, this does make a difference, pill size.
No, there absolutely are patients who pill size makes a difference. But I like to encourage them to try to get through that if they can't. But there are people who absolutely can't, and then you're going to have to consider a regimen. And again, we have the luxury today that we really can consider other regimens for people who pill size is a problem.
While we're talking about pill size, every so often, and it hasn't been as infrequent as I thought, someone will say, I'd rather take 2 small pills than 1 big pill. And the regimen of TAF FTC, which is now available, plus dolutegravir as 2 pills a day
Right.
is 2 really small pills, and that really has been,
Yeah.
very popular in some people.
Right. Although some people have difficulty taking pills twice a day,
Yeah.
it's not everyone. And
Yeah.
there are other people who are perfectly able to manage
Yeah,
it. So sure.
and that regimen's, of course, once a day, the
Right.
one I just mentioned. So what about this? You mentioned about travel, and people can get their refills early, but somebody has written in and says that it's impossible to do that.
Oh, well, it depends on, sometimes it depends on the individual insurer.
Absolutely.
I'm not saying that it's universally the case. It's certainly not legislated. It has to be the case. But I think some health plans have recognized that allowing a little flexibility in when you can refill can avert a person becoming non-adherent or missing a dose.
Yeah.
Now, that's not, there may be, depending on the place that a person lives, there could be either restrictions on, in the program they're in, there could be restrictions on that, and it's unfortunate. But I would hope that we'll be moving in the direction of helping our patients stay adherent.
No,
letting them.
I completely agree. It's quite variable. It depends a lot on the payer. Often the plans are, yes, if you plan ahead, you can get a refill early, but sometimes they're thumbs down. We have to be their advocates.
Right.
So I want to thank you, Dr. Brooks, for joining us today. This was a really fun discussion, and also thanks to our audience for the great questions.
Yeah.
I would also like to thank ViiV for their support of this important educational activity. So please remember to complete the post-test at the end of the session to secure your CME credits. And please visit idcarelive.com to view today's session, along with other infectious disease sessions on demand. Now stay tuned for our next session, which is entitled Innovations in Antiretroviral Therapy Formulations. My name is Dr. Paul Sachs. Thank you for joining us, and we'll be back shortly.